Thanks so much for coming out of the conference to have a quick talk to us. I'm wondering, as you know, we're doing a couple of little clips for GPs, general practitioners and ED docs in New Zealand. What message do you have, if you can put it in a nutshell, about the latest research for LAM for people in New Zealand who really want to know what's happening?
So for primary care physicians and for emergency room doctors, I think a primary message would be you should be suspicious about this disease in a young woman who develops a pneumothorax. Especially a non-smoking young woman, young defined by ages between 25 and 55, who develop a first pneumothorax. About 5% of those patients will have LAM. So it's important to be cognizant of the disease in that particular population. And for physicians who are following LAM patients that are primarily seen by, or also seen by pulmonary physicians or specialists, I think that the symptoms that we'd like them to be aware of are that LAM patients can develop unexpected changes in their ability to breathe, and there are many causes for that, including infections such as pneumonia and bronchospasm, an asthma-like problem, and chylus effusion, sometimes development of pulmonary hypertension. And in some cases, lymphatic fluid can actually back up into the lung tissue itself and cause kind of a pulmonary edema of sorts that's really a congestion with lymphatic fluid. So those are the things we think about when a LAM patient becomes short of breath.
Thanks. I mean, it's very, very clear that there's a huge amount of work being done in all areas of the clinical work that you're talking about, and it is clinical people who will be watching this and looking to see what is happening in the US, and of course we're involved in research in New Zealand in collaboration with the US as well. So the key messages are watch out for this young woman who may actually put your feelers out to think, hey, what's this?
Exactly. And the first thought that will come to a physician's mind when a young woman walks in and says she's short of breath is that she might have asthma. And most LAM patients are misdiagnosed with asthma for years before someone thinks of this possibility. And the difference between asthma and this disease is it doesn't have the classic exacerbations and remissions that asthma has. It's a much more steady decline than is seen with asthma. So if you see a young woman who has a pattern that looks like COPD and she's never smoked, you should be thinking about other diseases.
I was wondering if it was any particular clue that a young woman arriving at her primary care doctor's rooms, in fact, who's perhaps just had a baby, or in fact is pregnant and has chest pain. What would you suggest here?
Yeah, that's, shortness of breath during pregnancy is a fairly common issue, and it's only very infrequently going to be due to LAM. The incidence of this disease, a prevalence of this disease is about 5 women per million women. So there'll be hundreds of thousands of cases of just routine shortness of breath related to pregnancy before you'll find your first LAM case causing shortness of breath associated with pregnancy. But I think that's more of an issue for the specialist, a pulmonary physician who would have a patient referred to him because of shortness of breath during pregnancy. That's likely a more severe case. But I think the misdiagnosis as asthma is an important point for the primary care physician just to be aware that if it doesn't behave like asthma, perhaps you should be thinking about something else.
And the research that's happening, how excited are you in terms of rapamycin and analogues and rapamycin with combinations? We've been talking about it for 3 days here. How does that feel for you? Oh,
fantastic. I mean, I think we're very lucky to have a suppressive therapy that works. It's not perfect. It doesn't induce a remission. It doesn't cure the disease, but neither do medications for high blood pressure. They don't cure high blood pressure, they suppress it. And medicines for depression don't cure depression, they suppress it. And this drug works as long as you're on it, it appears, and its side effect profile is reasonable when given in low doses. That's why it's so important for primary care physicians and emergency room docs to be aware of this disease, because we do have an effective treatment. There is an intervention that matters, so if you don't think of it, if you don't find it, then this person will decline under your nose without the benefit of therapy.